Hi, my name's Julie. I'm one of the advanced clinical practitioners, and today I'm going to talk to you about induction of labour. The majority of women in the UK will go into labour spontaneously between 37 and 42 weeks. However, a third of women may need induction of labour, and this may be for various reasons. For example, if you go past your dates and spontaneous labour doesn't occur, or there may be some medical indications like concerns to maternal or fetal well-being. So when we are trying to start an induction of labour process, there are different stages to it, and we are trying to mimic the natural processes your body will undergo when it goes into natural labour. The first stage will be offered by your community midwife, and that's something called a membrane sweep. During your 39 and 40 week appointment, your community midwife will have a conversation with you and offer membrane sweep, which will involve a vaginal examination. And if your cervix is dilated just slightly, then the midwife will be able to pop a finger inside the cervix and literally sweep around. What that does is it lifts the membranes off the floor of your uterus and releases your own natural prostaglandins that can stimulate labour. If spontaneous labour doesn't occur, or there are reasons why you may need an earlier induction, then this will be booked via your badger notes. Unfortunately, we're not able to give you time for your induction because of the nature of pregnancy and labour. We can't predict how many people will go into labour. So a booking form will be completed by either a community midwife or one of the medical team, and you'll be given an appointment. On the day of your induction, you will receive a text message confirming you are booked for induction of labour, and you should then receive a telephone call between 9 and 3 from the birthing centre coordinator. Please don't call between those times because it's very busy on the unit and we often still won't be able to give you a time. However, if you don't hear anything by 3 p.m, please ring the birthing centre just as a prompt to let them know that you're waiting for a phone call. On arrival to the birthing centre, you'll be greeted by the midwife who's going to look after you during your stay. You'll be taken to one of the birthing centre rooms, and you will have a baseline set of observations. So your temperature, your blood pressure and your pulse will be taken. A presentation scan will be performed just to confirm that baby is head down. You will then have a monitoring of the baby's heart rate, commonly known as a CTG. There are two processes available to you for induction of labour. The first method is mechanical induction of labour, where we don't use any drugs and we use a cervical ripening balloon, which I'm going to discuss with you. The second method is to use prostaglandin drugs to stimulate the cervix to become more favourable, and again I'll discuss this with you. Mechanical induction of labour is a process where you will have an internal examination, and the midwife will gently insert a very thin catheter through your cervix to the other side. It's very soft on the top, so there's no risk of harm to the baby. This catheter tip has a little balloon on the end, so I'm going to just inflate it so you can see. So they just gently inflate the balloon while it's inside. And that just sits nicely inside your uterus and puts some pressure on the internal opening to your cervix. Now, this has been shown to be a very safe and effective method of induction of labour. The top of the balloon lifts the membranes up off the floor of your uterus, and the bottom of the balloon puts pressure on the internal opening of your cervix. Once that has been put in place, you will be given the option of taping the end of the catheter to your leg. Now, there is evidence to support this is much more effective if you do have a little bit of tension on here, because it just encourages a bit more pressure on your cervix. However, that can be a bit uncomfortable, and if you don't want to have that tension, that's absolutely fine. We can just take that tape off and just let the catheter hang, or you can tuck it inside your vagina if you prefer, if it's uncomfortable. That catheter will stay in place for a maximum of 24 hours. If your cervix dilates, which we're hoping it will, the catheter will drop out, and it normally drops out when your cervix is 3 centimeters dilated. Now, normally your cervix is a long closed tube. It's normally about 2 to 4 centimeters long. The idea of this catheter is it's going to shorten your cervix and dilate it. If your cervix is very short at the point that we rupture your membranes, it is shown to be much more effective at shortening the time between rupturing your membranes and delivery of the baby. So although it may seem like a lengthy process having it in for the 24 hours, it is much safer and can mean a shorter labour for yourself. If mechanical induction of labour is not appropriate for yourself, or we have tried it and it has been unsuccessful, the second line of induction would be to use prostaglandin drugs. There are 3 different formats used nationally, and it very much can depend on the availability for the drugs. Normally the first line would be prostin gel. So the process for induction would be exactly the same. Once you've had your monitoring of the baby's heart rate, the midwife would do an internal examination. If your cervix is long and closed, then they would insert some prostin gel. If it's prostin gel that's been inserted, you'll have further monitoring of your baby's heart rate. Once that's completed, we'll encourage you to be up and about and mobile, because gravity helping that head down onto the cervix is really helpful for getting you into labour. You'll be examined again 6 hours later. Now you can have a total of 3 prostins. Now if they're 6 hours apart, it may be that you don't actually go into labour until the following day. A second method of prostaglandin is a tablet called misoprostol. Now this is an oral tablet that will be given to you with a full glass of water, and you'll be given 1 tablet every 2 hours until labour occurs. The third method available is something called a pessary. So this is prostaglandin that's on a very small pessary with a long ribbon at the end of it. This again will involve an internal examination, and the pessary is put inside your vagina, going across the opening of the cervix, and there is a slow release of prostaglandins to stimulate your cervix to shorten and dilate. That will stay in for 24 hours and then be removed. Once the balloon has been removed or your cervix has dilated, we would then offer artificial rupture membranes, commonly referred to as ARM by the midwives. So the midwife will perform a vaginal examination, and she will use an amni hook. Now don't panic when you see the amni hook, only a very small part of the hook is placed inside. But we normally, if we're right-handed, do the examination with our right hand, hold the hook with our left hand. And you can see it's very smooth at the top, but just hidden underneath is a very, very thin little hook, and only about this much will go inside. So the midwife during the examination will just slide this up for her fingers, turn it round and press and put a little hole into the membranes. Once the amni hook's removed, the midwife will gently just make that hole a little bit bigger with her fingers. The release of those waters quite often will then stimulate labour and start your contractions. Once your waters have been ruptured, if you start contracting regularly, sometimes that's the end of the induction process and labour just continues without any further interference. However, contractions don't always occur, and we need to then go down the final step of induction, and that again is mimicking the natural processes your body undertakes. Your body will produce oxytocin, which is a hormone. The way this hormone works is the more that you have, your brain detects rising levels, so it will start producing it. By giving you a synthetic version of this hormone, we can stimulate your brain to stimulate your natural production of oxytocin. for that reason, anybody having an oxytocin infusion, we do recommend continuous electronic monitoring of the baby's heart rate. This doesn't mean you need to be strapped to a machine. We have wireless telemetry machines, so you can still be up and about. It just means that we need to be continuously monitoring the baby's heart rate, making sure that baby is coping well with the contractions and that you are not having hyperstimulation. We would like ideally 4 contractions in a 10-minute period so that you get nice gaps in between and you're not overstimulated.